Hi, I'm Dr. Andrew Neviaser. I'm a shoulder and elbow surgeon here at OrthoVirginia, and I'm going to talk to you today about a condition that has a lot of myths and wives' tales about it out there called frozen shoulder. This is a condition that is very, very common. It's one of the more frequent causes of shoulder pain, and the term frozen shoulder is thrown around a lot. And I hope with today's discussion, I can provide you with an understanding of what true frozen shoulder is and explain to you how we go about choosing treatment options. This is also a condition that for me personally is very near and dear to my heart because I'm a third generation orthopedic shoulder surgeon, and my grandfather was the person who discovered this condition and gave it its medical name, which we referred to as adhesive capsulitis. And then my father and his brothers published many significant papers on the staging system for this, and it was an area of research for me early in my career. What true frozen shoulder is a problem of something called the capsule of the shoulder joint. And you may know that the shoulder is a ball and socket, but you may not know that that ball and socket is surrounded by a thin film that looks almost like a balloon, and it holds inside the fluid that gives nutrients to the cartilage and other tissue inside the joint. That lining is typically extremely thin. You can see through it. But in the condition of adhesive capsulitis, or what true frozen shoulder really is, that capsule gets first very badly inflamed and it causes a lot of pain. And then it literally shrinks up and adheres itself along the bones of the shoulder. And that severely restricts people's movement. So it's almost like someone shrinking up your sleeve. So you try to raise your arm up and you can't. Try to reach up your back and you can't. One of the more common complaints I hear from people who suffer with this condition is that when they go into a parking garage and they try to grab their parking ticket, they can't quite reach to get it. Typically, there is not any significant injury that causes this, and it is important to recognize that this is a distinct problem in and of itself, and it is not the same as having a stiff shoulder from other conditions like shoulder fractures or torn tendons or calcium deposits on the shoulder. To have true frozen shoulder, essentially there should be nothing else wrong with the shoulder. Other conditions can cause stiffness, but if you treat those other conditions, the stiffness will go away. And that's in part what makes frozen shoulder unique. It tends to happen in females more than males. About 70% of people who get it are female. It's often occurs between the ages of 40 and 60, and slightly more frequently in the dominant shoulder than in the non-dominant shoulder. People who have any type of endocrine abnormality, such as diabetes or thyroid conditions, more frequently suffer from this problem, particularly diabetes, and often have a longer and more frustrating course of treatment if you have those conditions. If you've had frozen shoulder and now you're worried that you may have one of those conditions, you should not be. We have studied whether or not just having a frozen shoulder should prompt us to investigate whether or not we should test you for things like diabetes, and the answer is very clearly no, because people who don't have those conditions get this as well, but diabetes is a significant risk factor, as is thyroid problems. It is often something that patients come in to see us having been given that diagnosis already. However, it is far more common that patients come in and have been told that they have frozen shoulder when they do not, rather than they actually having frozen shoulder and someone has made the correct diagnosis. And there's a few key things that we will look for in our physical exam and when we gather the history from our patients that are keys to this. the physical examination of a frozen shoulder is very, very distinct. And so it's important, if you're seeing a physician who is for your shoulder pain, that they actually perform a complete physical exam on you, because there is this sense that the shoulder is tethered when you try to move it in frozen shoulder that no other condition produces. There are really two things that will cause stiffness in isolation, arthritis being one, but we typically get an x-ray to make sure that arthritis is not there, and then frozen shoulder. And so when people come in and they get the diagnosis of frozen shoulder, they're often concerned that there's something else going on in their shoulder, and they sometimes request an MRI. Usually, when we've gotten x-rays, those x-rays will be normal. MRIs, however, will demonstrate any number of findings, most of which are highly insignificant. About 20 to 30% of people who have a frozen shoulder will have what are called partial thickness rotator cuff tears on their MRI. Those are essentially a normal part of aging and don't need an operation, but often get patients very worried when they see that on their MRI report. It's also quite common that the radiologists who don't know that these patients have frozen shoulder will identify rotator cuff issues at the attachment of the tendons, which happens to attach right next to that capsular lining of the shoulder joint. And so when that MRI signal is generated, the inflammation in the capsule will create a bright signal right next to the tendon attachment, and the radiologist will also often question whether that's a tear, when in fact it's just the inflamed capsule of the adhesive capsulitis or frozen shoulder. Other things that we'll see on an MRI is we'll see the actual thickening and contracture of the capsule, and that can confirm the diagnosis, but it's typically not necessary to make the diagnosis. Usually the diagnosis is quite evident. So it's critical when you see your physician that do a complete examination, that get an x-ray of you to rule out other possibilities. And then when they make the diagnosis of adhesive capsulitis or frozen shoulder, they steer you down what is a very, although effective, role sometimes of treatment in terms of physical therapy. It can often be quite frustrating for patients, because although we are very good at getting this condition to go away without doing surgery, it's very difficult to make it go away quickly. And after the diagnosis is made, you have several options for treatments. Medicines, of course, are always one of them. But what most patients will find is that oral medicines, things like Advil or Aleve, or even the prescription versions of those, don't provide them with very significant relief. There are other more powerful medicines that sometimes are prescribed for this. They are called steroid medicines, as opposed to the non-steroidal medicines like Advil. Steroids are, although frequently helpful in other sources of pain, have quite a few side effects and are often very ineffective for this condition. Because oral medicines aren't very effective, injectable medicines, again, corticosteroids as well as other injectable medicines, are often used. There are mixed results when using injectable medicines. Steroid medicines injected into the shoulder can be helpful for this condition, but helpful in the sense that they will give you about 6 to 8 weeks of improved pain, but they won't actually change how long it takes this problem to get better. And I've been so far a little bit deliberately vague in telling you how long it can take adhesive capsulitis to get better, because this is the information that I think patients find so frustrating. 90% of people who get this condition can get better just with a treatment of physical therapy and don't need surgery. But it can take as much as 8 or 12 months, sometimes even more, for their symptoms to totally resolve. There is a fairly predictable progression of symptoms in this. Most commonly, it starts with pain, and that's when that capsule that I mentioned before is very badly inflamed. As that capsule begins to shrink and tighten up, there's also a loss of motion. So then you experience both pain and stiffness, and that's often the most frustrating stage. After the inflammation begins to subside, the pain diminishes, and you typically have pain only when you try to reach or move the shoulder beyond the limits of that tight capsule. And so patients are often more comfortable but still frustrated because their arm doesn't go all the way up, or they can't reach their backside and their motion is still limited. But ultimately, that also tends to resolve. But again, it can be 8 or 12 months later. And the purpose of physical therapy really is just to stretch out that capsule. And oftentimes I get asked how vigorous physical therapy has to be for this condition. And that's a question that has been asked many times in the past. And we've studied it with several research trials looking at very intensive physical therapy where therapists are told to push past pain. And when we've compared those to groups that do less intensive therapy, where the therapy is not painful, what we find is that both groups actually improve quite substantially. And there are only very small advantages to having a very intensive therapy protocol. So many patients are often afraid of physical therapy because they think it's going to hurt. It does not have to hurt a lot, but you do have to stretch this out every day. But overall, the prognosis for having a frozen shoulder is quite good. We here at OrthoVirginia are also very lucky because I have some partners who are non-surgeons that we collaborate with in treating this condition that can perform a procedure that's not a surgery, can be done in the office, but is quite an effective treatment for this condition, and it's called hydrodistension or hydrodilation. And basically, what they do is we use the guidance of an ultrasound to place a needle within the shoulder joint, and then they insert fluid into the joint and distend the capsule until basically it pops. And this releases the tension in the capsule and allows the shoulder to move more freely. And it's an excellent jump start to doing physical therapy. This is a procedure that's quite popular in Europe. It's not quite as popular in the United States because we don't have as many practitioners who are capable of doing it. But at OrthoVirginia, we have several. And so we're lucky to be able to offer that to our patients. And it's a good option for people who are looking to do more than physical therapy but aren't ready for surgery. There are patients who get this condition and ultimately need to have surgery. And more often they are patients with diabetes, but it's not solely patients with diabetes. Around 10% of people who get a frozen shoulder ultimately has to have surgery for it. And what we do when we do that surgery is we just put a little camera in their shoulder and we use a little probe that can cut that capsule, and we work all the way around 360 degrees, release the capsule off of the bone, and that allows the shoulder to again move freely. And it's an excellent treatment for those who need it, but most do not. I tell people very carefully that it is not an immediate cure for the frozen shoulder. It allows therapy to begin and work more effectively. So most people who get that surgery will go right into physical therapy that same week, even the next day. And it still requires some work afterwards. But ultimately, this is a condition that typically can be worked out over time. It is a condition that is very frequently diagnosed, often misdiagnosed. But when you have true adhesive capsulitis, you should be optimistic, but also patient, because as I mentioned, we're good at making it go away, just not making it go away quickly. So I think that's pretty much what people need to know. I'm happy to take some questions if we have some.
We do have some questions. Thank you so much, Dr. Neviaser. So we will be answering questions submitted earlier and questions submitted live. So if you are watching this live, you can go ahead and leave your question in the comment box. Not all questions will be able to be answered, but we will be answering a bunch of them. So our first question is, can elbow joints freeze like shoulders?
So it is extremely uncommon, to the point where I would say it's rare for elbows to have a true capsulitis problem. However, it has been reported in elbows. We are much, much more aggressive at looking for some alternative cause for loss of motion than we are in shoulders. In shoulders, it's common. In elbows, it's flat out rare, but it can happen.
Thank you. If I get frozen shoulder in one shoulder, am I likely to get it in the other shoulder?
Yes, that's an excellent question. So the answer is yes. There is anywhere 30, maybe as much as 40% chance that you'll get it on the other side. And when I was mentioning the benefits of steroid injections, I mentioned that they were fairly limited in this condition. There's one caveat to that. In a laboratory, if we take cells in a petri dish that are functioning in the way that the cells of the capsule do in frozen shoulder, meaning they're becoming stiff, they're turning into scar. If we get them in that very early inflammation stage and we put cortisone on them in the lab, we can stop that process. Most of the time when patients come to see us with this problem, they've already passed through that initial solely painful phase and they've got some stiffness. When they have stiffness, the shots don't work quite as well. But the few times we can get people in early are people who've had frozen shoulder on one side and start to get familiar symptoms on the other side. I usually will tell people, if you have pain on the contralateral side that seems familiar, come in right away and we're going to try a shot of cortisone, because there is a theoretical only chance that we could knock this out before you have to deal with stiffness. And sometimes you can do that, but it is uncommon to catch a patient early enough where you can have that effect.
Thank you. Can you get frozen shoulder in the same shoulder twice?
No. So that's one of the unique things about this, is that you cannot. And it happens once and once only. So I think I have definitely seen people who have frozen shoulder and they have been told in the past that they had it in the same shoulder at a different time. But remember, I mentioned to you that it is a diagnosis that is often misused. And I think for the most part, people throw it at anyone who has pain and inability to move their shoulder, which can be from lots of causes. But overall, frozen shoulder or adhesive capsulitis only comes once and once only.
Thank you. What is the difference between frozen shoulder and a calcification deposit?
So there are two vastly different things. Calcification deposits happen when your body deposits basically what looks like chalk that your teacher used on the chalkboard into your tendons. Very common to happen in the shoulder. And those produce a profound inflammatory reaction from your body, and they're exceedingly painful. What you will find when dealing with those patients is they're often unable to move their shoulder, but I can move their shoulder when my own hand is the motor. So they don't have true stiffness. Stiffness is defined as a shoulder that can't be moved by me as the physician rather than the patient. And so calcific tendonitis can cause pain with motion, but it doesn't cause true stiffness. And it's for a totally different reason.
Thank you. Does having frozen shoulder mean that you're more likely to have other shoulder issues, like having a torn rotator cuff or needing a shoulder replacement?
No. So the likelihood that you have a truly torn rotator cuff, meaning you have a hole in your rotator cuff that would be amenable to doing surgery, is actually extremely low when you have a stiff adhesive capsulitic shoulder. And there is no correlation with getting adhesive capsulitis and needing future shoulder replacements. Shoulder replacements typically are done for things like arthritis, and adhesive capsulitis does not lead to arthritis in the shoulder.
Thank you. Does acupuncture help frozen shoulder?
So acupuncture falls into one of these potentially alternative treatments that people are trying for a condition that I mentioned is quite frustrating. But it is often very difficult to prove that any treatment is effective in a condition that tends to get better on its own. Because if you give some people acupuncture and don't give acupuncture to others, in a condition that gets better on its own, pretty much everyone will get better over time. So the answer is, I don't know. I don't normally prescribe it because there is some risk in getting stuck with needles. But overall, I think there's limited data to suggest that it is helpful.
Thank you. Are frozen shoulders related to menopause?
So this is a very, very common question, and I think there's been some things on social media about this quite recently because I've been getting it a lot. And remember, I said that any hormone abnormality, and I mentioned diabetes many times, but it's really any hormone abnormality, you can find some correlation to frozen shoulder. And we think that there is probably something about systemic hormone production that's related in terms of a cause for frozen shoulder. But we don't have enough information to use that when we treat people. So can it be related to changes in hormone production because of menopause? Yes, it can. And I know there's some ongoing investigations looking at hormone replacement therapy and things like that, and whether it's reducing the incidence. Those are still in their kind of infancy. It is not something that we routinely suggest for people as a means of preventing adhesive capsulitis, because there are, of course, some risks to getting hormone replacement therapy as well. So the answer is yes, but we're not sure how we're going to use that information quite yet.
Thank you. If someone is recovering from frozen shoulder, should they expect their strength to return to the level it was beforehand?
So frozen shoulder should not really affect your objective strength in the sense that it doesn't really have any impact on the muscles and tendons other than you can get some atrophy because of limited use. So when you improve, your strength should go back to pre-injury levels. It may take a while to get there, but strength is not something that we typically worry about getting people back to. Sometimes there can be some very, very small and really insignificant losses of motion. When we look at long-term studies of frozen shoulder, what we find is if you put people in very careful measuring machines and check their motion, you can still figure out which shoulder had the frozen shoulder compared to, say, the other normal side. But the differences are so small that patients don't actually even notice. So they will tell you that they're fully recovered, even though you can see a little bit of loss of motion even decades afterwards.
Thank you. Do certain activities or workouts make someone more prone to frozen shoulder?
No, quite the contrary. Keeping active and keeping your shoulder mobile, at least theoretically, may be the best means of preventing this problem. It's not a guarantee. I see lots of very active people who get this, but you will not make it worse by doing activity. It can cause more pain, but it doesn't cause structural damage to your shoulder. And there aren't any specific activities that I would tell you will precipitate a frozen shoulder.
Thank you so much, Dr. Neviaser. That's all the time we have for questions today. Would you like to close?
Oh, thank you very much for having me. I think I hope I've shed some light on what's a fairly complex and murky subject. If you have questions about it, I'm more than happy to sit down and talk to people. And if they have concerns about their frozen shoulder, come on in. We're happy to take a look.